So we have about
morning, everyone. Mingalaba. It is my pleasure to welcome you this morning for this webinar on chronic pain management, the balancing act. Today, Zydus is launching a very important molecule for pain management, it is etodolac. Set the wheel in motion for this webinar and tell you more about this launch. Let me first invite the country manager for Zydus Myanmar, Mr. Ram Subramaniam. Over to you, Mr. Ram Subramaniam, for giving the audience an appraisal about this launch.
Here, Dr. Hardik.
Sorry.
Yeah, we can hear him, sir. You can proceed, please.
Hello.
Yes, Ram sir, over to you now.
Yeah, thank you. Thank you so much. You can hear me, Sesh?
Yes, we can hear you, sir.
Yeah, thank you. Good morning, all. This is Ram, country head for Zydus Alidac, Myanmar. It is my great pleasure and privilege welcoming you all for this wonderful scientific session being scheduled for today. As you know, Zydus has been in Myanmar for more than 2 decades. And what is more, giving me more pleasure is that most of you know that we have installed the pharmaceutical manufacturing facility in Myanmar. I think this is the first multinational to put a factory in Myanmar. So we are very happy and glad to provide service to the people of Myanmar. Secondly, the most pleasure thing is that when we have put a factory in Myanmar, it is not just producing the medicines which was already available to our country. It is something new we can provide consistently to the people of Myanmar. So I'm very happy that the product which will be launching today, Itogesic, which will be manufactured from this very facility. So it is another milestone for. And I am thankful to our chair, Professor Uchitsu, for giving us in framing this symposium. I'm also thank our own respected Professor Rohini Handa, and we are great friends. I think Professor Show will introduce about Rohini Handa. Personally, I know Professor Rohini Handa for more than close to 2 decades now. While I was handling assignment in India, he's a very, very humble, simple gentleman and a great academician. This is very rare. We can see that somebody very good in clinical practice and somebody is very good in academics. So very fortunate to have you here and accepting our invitation to be here, sir. Thank you so much for that. And thank you, Professor Myint. It's another stalwart in orthopedics. Like when we talk about orthopedics in Myanmar, he is one of the pillar for Myanmar in creating so many orthopedic specialists in Myanmar. So thank you so much for being here. Today, we are going to have this very interesting topic about chronic pain management. And as most of you know that, Zydus has already have Leucoxia and Zysel. So why, another painkiller? So we are very happy to provide another weapon in the armamentarium to take care of the pain, because different people needs a different stroke, and looking at different need of the people, a different category of pain, I'm sure this etogestic will be very useful for the patient suffering from chronic pain. And thank you, Dr. Hardik. I cannot just miss you off. You are the one who has been the fulcrum for creating all scientific sessions for entire EMB. So thank you so much for helping us in organizing this symposia. So once again, I welcome all the panelists, chair, and the participants to have an experience and wonderful symposia. Thank you so much.
Thank you very much, Mr. Ram, for welcoming all the delegates as well as the panelists for this session. And now, ladies and gentlemen, let me begin with the scientific session. And to chair the scientific session, we are very fortunate to have Professor Chit with us. And it is a privilege for me to introduce him to the audience. Professor Chit, Senior Consultant Rheumatologist and Emeritus Professor at the University of Medicine 1, Myanmar, is the founder of the first rheumatology department in Myanmar and founder and president of the Myanmar Rheumatology Society. Professor Chit is the chairman of the Ethics Committee for Myanmar Medical Association and the Internal Medicine Society. He is also the module supervisor on communication skills for Diploma of Medical Education course and Diploma of Communication and Medical Ethics course with the Ministry of Health. Professor Chitso's interests include medical education, communication, rheumatology, and tropical diseases, with him having over 100 publications on these subjects in national and international journals. Professor Chitso, I welcome you this morning for this webinar and request you to please take the proceedings forward by introducing our first speaker.
Thank you, Dr. Hardik, for introducing me nicely. Yes, this is a good time to refresh our memories about the pain management. In our daily practice, especially after the COVID, we had a lot of complaint about pain, musculoskeletal problems, and we have a lot of painkillers in our hands, but no one is perfect for everybody. So we need another painkiller now. And so let's see how is the new painkiller and what are the principles of treating pain. Whenever we have a new molecule, we have to refresh our memory again and again. So we had two prominent speakers during this discussion. So I would like to introduce or announce Professor Myint, already introduced by Mr. Ram as well. He is a patron and past president of the Orthopedic Society, so everybody will know what will be the huge experience of the pain management. So Professor Myint will discuss about the management of osteoarthritis pain in primary care. So very interesting. So not in the tertiary care, it's a primary care in day-to-day practice. So Professor Myint, please, for the discussion.
Start. Is it the beginning? No, beginning. Yeah. Good morning and thank you, Professor Chiso, our today section chairman, our eminent speakers, Professor Handa from the India, Dr. Hatik, Mr. Ram, ladies and gentlemen, and all audience. Today, our live webinar is focusing on the chronic pain management. So what is the balance act on the chronic pain management? As an orthopedic surgeon, as well as I was a previous president of the Myanmar Society for the Study of the Pain, I would like to share our experience on what is the current changing concept of the chronic pain management, what is the general recommendation in the clinical practice for the chronic pain management, and I would like to share our orthopedic experience on the osteoarthritis pain, focus on the knee joint. And I would like to elaborate more on the primary care setting. I'm sorry to say, exact prevalence of the osteoarthritis in Myanmar from the database, but it is expected to be equal prevalence among the ASEAN countries, which may contribute to about 40 to 50% of our cases. Also, arthritis of the knee usually accounts for the almost 4/5 of the burden of the osteoarthritis worldwide, and it is increasing prevalence with the obesities and aging process. We should more focus and need to explore the etiology of the high prevalence and clinical incidence of the osteoarthritis knee, particularly in high-risk people like women and elderly patients, with the positive outlook on the preventive strategies, particularly in the early stage of the disease, which is usually happen at the community level. According to the National Health Statistics Report, musculoskeletal pain disorder is still more than 50% of the prevalence of the total pain cases in the community. According to 2009 service, household surveys in the Singapore that we have been discussed with the Pain Society in Singapore, the chronic pain incidence is about 8.7% of the total populations. They have been suffering from the pain for more than 3 months duration, with or without treatments. That contribute to nearly 11% in the female populations and nearly 8% in the male populations. There was also similar studies in the Philippines that account for nearly 14%, and in Hong Kong, nearly 11%. This is the rough data in our chronic pain clinic, which is situated in Yangon General Hospital that was run by multidisciplinary pain. According to this data, we have been reported to the International Pain Society. Musculoskeletal pain is still the most common visiting patients in the pain clinic. In orthopedic practice, knee pain is common language after the age of 50 years in both sexes. Primary OA knee is more common than the secondary OA. 1/3 of our cases is attended as an outpatient clinic. 2/3 of cases represent the fragility hip fractures. They have already symptomatic OA knee and sometimes accompanied with the spinal degeneration as well. Most frequent visits to the specialist clinic in our private and public sectors, and under-calculated healthcare costs for the treating osteoarthritis of the knee. And I should say, most unsatisfactory long-term outcome after the medical treatments in the OA knee joint. Pain as a leading cause of disabilities. There are many deleterious effects on the ability to walk, functional expectation, quality of the life, impact on the immune system, impede even in the wound healing process, associated GI and pulmonary dysfunction, suppress the individual appetite, alter the sleep pattern. Sometimes chronic pain patient has loss of weight and loss of calories, and even in our surgical practice, delay amputation after surgery because of the pain, if periodic pain management is unprogrammed. What about pain in Asia? 41% reported that pain affected their work. 14% of the working days lost can be attributed directly to the pain. 75% of the those taking sick leave for pain in the last 6 months require at least 14 days off. This is very similar in our outpatient practice in the public hospitals. The great art of life is sensation. To feel that we exist even with pain is already said by the Lord Baron. What should be the working definition of the pain by the physicians? It is a sensory and emotional experience requiring consciousness. It's subjective, personal phenomenon, and multidimensional. The extent of pain is a result of complex interplay of the system, signaling the nauseous stimuli and pain modulating process. What we understand about the pain in the real practice: pain is a vital, pain is fatal, pain is modifiable, pain is preventable, and pain is curable. Treating the pain is right to treat. IASP already stated in the last decade that access to the pain management is everybody's fundamental human right. If we look at back to our healthy human joint, it involves concern with biology as well as mechanics. We need good catalytic neuration. We need good capsular and also collagenous support. We need fluent synovial fluid. We need sensitivity and proprioception of the individual joint. In terms of the mechanics, structure, designs, and function of the individual joint, their coordination with surrounding joints, their equal stress distribution, structural, both static and dynamic stability, and functional mobilities are the characteristics of the healthy human joint. OA is not the really aging disease. It is quite different from the aging process and pathological process of the osteoarthritis. The water content collagen, proteoglycan content, proteoglycan synthesis, control site size, control site numbers, and modulus elasticity of the mechanical property is quite different in between aging and also arthritis. It is shown in this figure. If we consider the origin of the joint pain in the sense of the clinical symptoms, there are abundant extra-articular innervation around the joints, but relatively less innervation in the inner cycle of the joint, like cartilage, meniscus, and disc, etc. The real anatomic etiology of the pain in the painful joint is not well understood because of the complex nature of the pain origin and also underlying complex pathology and accompanying physiological conditions. The nociceptive symptom of the joint is usually overwhelmed by the mechanoreceptors. That's what we call the silent nociceptors, which usually respond to any stressful stimuli on the loading process of the individual joint, particularly in tension stress. That is ISP defined as an evoked conscious sensation. Pain in every deep-seated structures like joint is delicate in nature, sometimes poorly localized by the patients, and each and every time is motion related, and sometimes often associated with the loss of accompanying musculotendinous strength. Cytokines in acute inflammation of the joint is involved in both peripheral as well as central sensitizations. TNF-alpha and interleukin-6 are the key cytokines in the peripheral sensitization of the joint pain. Whenever the repeated inflammations or repeated mechanical stress over the joint, causing development of the hyperexcitability of the spinal cord neurons, and all the message transferred to the brain, and pain become disease itself. That is what we call the central sensitization. It is interesting to note that pain severity with structural damage is poorly correlated each other. You may see the very bad radiological evidence of the joint, but patient has less pain. Sometimes radiologically appear near normal, but symptoms was there. That is the reason some studies has been shown that there may be positive and sensitive correlation between the early MRI findings and intensity of the pain. We also do practice in some of the unexplained pain in the joint. We need to take the MRI in the early stage before the plain radiological structural damage. Individual variability in perception of the pain may be taken role with the individual genetic predominance. If the pain perception is different in every individual, the answer is yes. Pain is usually recognized not only as a sensory experience, but also as a phenomenon with affective and cognitive components. Especially, it is very obvious in chronic pain patients. It will be variable with the age, variable with the gender, individual or country culture, their communication skill level, previous bad experience on pain, and individual coping capacities. Whenever we consider to treat individual chronic pain, we should think of everything in place. As the osteoarthritis has many modified and non-modified risk factors, they are interfaceted, complex, and interlinked. This will be associated with the incidence of the risk patient. So we need to identify the all patient with OE knee by the clinical diagnosis as well as the risk stratifications. even as a surgeon, if we consider the realistic indication for the surgery, other realignment surgery or reconstructive surgery, the surgeon should take into account of all these risk factors. Otherwise, satisfaction rate of the patient will be low. All the predisposing, initiating factors and perpetuating factors are totally end up with the treatment failure. That is what I would like to stress on the fundamentals in the preservation of the joint health. Medicine, exercise, and everything are important, but for the fundamental preservation of the joint health, biological integrity and strength of the joint and surrounding structures is also important. Articular congruency for the load distribution, strength of the dynamic structures around the joint, mechanical stability and anatomic alignment, mechanical alignment with even distribution of the joint ground reaction force, motion free with the painless range of movement, coordination mechanism with the other joints, and finally, neural pathway and positional center of the joint function as well, even indeed to the joint replacement. When we consider to prevent the chronic pain, we should have adequate acute pain management, trying to stop the peripheral sensitization as early as possible, trying to stop the progress on the central sensitizations. Peripheral sensitization is an implication of the signaling in nociceptive fibers causing pain hypersensitivity. Central sensitization is implication of CNS signaling causing the pain hypersensitivity. At this stage, pain is not only symptomatic, pain itself becomes a disease and very difficult to manage at that time. As I already mentioned in the previous slide, pain and sufferings they going together whenever pain cannot be relieved for more than 3 months with accompanied biopsychosocial distress. So 2 important strategies for the pain management, especially for the chronic pain. Number 1 is to reduce the risk factor if you can identify it. You need to enhance the protective factor if it is identifiable. So there are both protective factors and risk factors we need to consider together in order to prevent from acute pain to the chronic pain. We're trying to decrease the risk factor and we're trying to increase the sum of the protective factors as well. Why the primary care setting is important? Nowadays, if you want to get the complete total managed care, we need to be strongly integrated in between the primary care level and institutional care level. We need to work together, especially in the chronic pain management. So goal of management of osteoarthritis is we need to slow down the disease progression. We need to maximize the functions. We need to manage the symptoms whenever it occurs. Managing symptoms is most important in the acute care setting, either at the primary care level or institutional level, in order to prevent the pain, in order to stop it becomes centrally sensitized in our CNS system. Establishing the diagnosis of at the primary care level is very simple. We need to identify the high-risk patient. We need the thorough clinical examination. And we need to stratify the risk factors, other possible disease, especially whether it is the inflammatory condition or it is in the sepsis condition or even the malignancies of the internal structures. If you look at this diagram, The pyramid of the management of osteoarthritis is quite variable at the different clinical settings. In this pyramid, the basic level at the community level, primary care level, has more prevalence of the patients in our community. Our primary care physicians and basic care staff can stop this kind of osteoarthritis management at the basic level. Just information and advice and self-help or self-management program, it can be provided at the different levels. It's very cost-effective in terms of the primary care level. Why it is important? Because our patients, about 40% in the population have lifetime risks of osteoarthritis. Everybody know that. More than 25% of our patients with osteoarthritis has difficulty with activities of daily living. If you miss the primary care and effective acute care pain management, many patients will finally refer to the surgery. So we will need added to the healthcare burden as well. According to the evidence-based intervention to reduce the pain management and disability at the community level, we have established self-management and non-pharmacological strategies. We must start with the self-management program, non-pharmacological strategies. I would like to stress on that in this program, patients and their family should be the key member of our team for the integration of this self-management program. Exercise and weight loss. All patients with high BMI, more than 25 kilograms per square meter, need to be recommended to reduce the weight. This has a significant implementation on the pain reduction, functional scoring, and overall quality of the life. So the role of physicians, nutritional specialists, and educationists are important to reduce the weight loss. According to 2020 ISB Pain Prevention Program, the organization strongly recommended on the healthy, well-balanced diet to reduce inflammation and musculoskeletal strengths, maintain a healthy weight, keep healthy lifestyle and postures, regular exercise, avoid repeated stress and strain to elevate the triggering risks, use the posture-friendly device and equipment, educate the patients, and train the individual chronic pain patient with the coping mechanisms, how to stay with the pain, self-control measures and assessments. It's very important at the primary care level. There are many quality indicators for the primary care of the osteoarthritis. It may be varies with the individual cultures and individual countries, but how much pain can be reduced by the given treatment, how activity or daily living is improved quickly, how your given drugs can have efficacy to improve the tolerance and compliance, how can recognize the patient's satisfaction, they are doing exercise and run recreation activities, least and tolerable side effects, cost effectiveness of the analgesics are important key indicators in the treatment program. So there are some of the indicators which is useful to assess the patient response at the primary care level. According to American College of Rheumatology and Arthritis in 2019, pharmacological management has been already recommended an evidence-based practice in different levels of osteoarthritis in hand and knee and hip. But we should be quite sure that individual response and individual biopsychosocial factors may have different response to your given treatment. It may not be the same in every individual with every kind of the treatment. Medication is also had different action at the different level, either CNS or spinal cord or peripheral nervous system that every doctor's knowing at the basic medical education level. Now, I would like to stress on the etodolacs. The role of etodolacs in pain management has been studied a lot in the previous years, and it has very good response and treatment in compare with the diclofenac. After the 4 weeks of treatment, it is quite comparable efficacies. It has GI safety, unlike the other NSAIDs, strongly reduce the abdominal pain, less GI hemorrhage, and no dysphagia as well. Etodolac is generic COX-2 selected inhibitor that can reduce cardiovascular as well as GI side effect and renal side effect. It is strong renal safety. Data from this over 1,000 patient study has been presented even after 4 to 52 weeks of the treatments with a dosage of 50 to 600 milligram. Renal function is still maintained. Short and long-term treatment with the etodolac in patients with arthritis does not appear to produce clinically significant changes in the renal function. Why primary care is important in the community? The role of etodolacs with the least clinical side effect and most patient compliance and satisfaction rate had unique properties which can be utilized in the management of the osteoarthritis patient along with the other non-pharmacological strategy, especially in the early stage. I should like to remind all the practitioners that there are some reflex signs. This reflex sign can have complicated or even worse if we miss it. Whenever the patient has intractable pain in spite of rest and the potent drug therapy according to regime, whenever a patient is seen generally being unwell, visible deformity and unbalance of the joint in activities of daily life, serious side effect of the given drugs, or loss of compliance, whenever also arthritis with 4 history, or patient is showing you the systemic illness, we need the specialist consultation. We need comprehensive assessment and investigation as well. 21st century strategy of pain care is now, which paradigm shift to the transformative care model. It needs to combat the pain, including shifting the care program to patient and family. They should engage, they should be educated, and they should be empowered patients' ability to participate in the treatment care program. Current medical practice is now shifting towards a human system model. It needs to combine with the transformative care model as well as interdisciplinary cross-professional team integrations. Whenever the patient is suffer from the chronic pain, not only the pathology, we should also focus on the body, mind, spirit, lifestyle, emotion, environmental, and society as well. Our regime and program should be flexible, personalized, multidimensional, encourage on the self-care program, patient-centered, and focus on the healthcare costs. One human system approach is important. Humans are complex, dynamic, multidimensional, and multifaceted lifestyle, and living within an ever-changing social and physical atmosphere with different interaction with external and internal stimulus. That is great concern to the chronic pain. So in principle, safety and efficacy of pain control is depend upon whether our medical practice is ethical or given to the patient with absolute right, humanistic and physiological approach, comprehensive clinical assessment and identification of the risk factors, targeted multidimensional modalities, least side effect and avoid addiction and dependence, cost-benefit strategy and standardized protocol, optimal patient satisfaction, professional practice, which will provide the clinical competency for the care providers. In our today practice, when the patient has failed to respond to the pain treatment because of the lack of patient coordination, because of lack of competency in diagnosis and treatment procedures, lack of risk assessment and stratification, lack of integration of the evidence-based guideline, lack of patient education, lack of facility-based system care, and lack of professional practice and unethical conduct. Pain treatment is not successively changing our treatment program quite frequently and irrationally. We need to find a target. So Joint Commissioner recommendation in 2020 has been already stressed on the careful assessment by the trained healthcare personnel. Pain care is everybody concerned, but if you want to give the good quality pain care, we need to train our healthcare personnel as well. Describe the pain characteristics in detail, take appropriate steps with individual design, ask for the alternative pain treatment rather than the strong analgesics, plan monitoring program for the drug control and patient response with database. We need to conduct physical performance activity progressional. So current recommendation on the medication is also combinations of drug with agonist and adjuvant actions, follow with gradual titration for the maintenance of therapeutic level for the safe long-term control. It is multimodal, multi-targeted analgesia in the acute stage. Technically, what we understand about the prevention of pain is every healthcare provider should have precautions for individual risks. We need to define the programming of the individual treatment schedules, protection of the possible damage. Whenever we give treatment designs, this should be precise on the targeted level, especially on the pain anatomy, rational prescribing of the medication, personalization of the patients. Who are the difficult patients? What we came across in our clinical practice. Anyone who have multiple anatomical pain, one after another with unmanageable distress. Any dying patient with pain, especially in the young families or incomplete families, difficult families. Those who have a troubled, difficult and struggling lifestyle before the onset of the illness. Those who have received wrong conception of the pain experience before. These all patients are very difficult patients to treat. I have some patients with this problem. I cannot solve it alone. What do you mean by total pain? This term was first used by the Demisici Saunders to describe the patient experiencing intense suffering of the pain, physically, spiritually, socially, and psychologically, and ultimately end up with unpleasant feeling of the pain giver, beyond the endurance and no solution at all. This type of patient, whenever I see in the clinic, I'm very much excited, and sometimes I myself become distressed with this patient complaint. So there is some role of the cognitive behavior therapy when our clinical psychologists to treat these type of particular patients are there. Whenever we consider the integrated approach to the assessment and management, not only focus on the pain, but also their sensory experience, their cognitive capacity, their effectiveness, their illness behavior, and their social psychological condition as well. This term is very interesting. What is bilateral pain control? As a team, our pain team caregivers should have positive therapeutic attitude, respect to the patients. Every approach should be humanistic. Every problem have high technical solution. Definitely cross-professional expertise is mandatory. Biopsychosocial factor is important to consider in every setting. Patient safety first and best possible service. So what will be the pain care in future? The emerging NSAID formulation like Etodolex with the nanotechnology and hydrogen sulfide releasing drugs will be appear. The role of interventional pain therapy, role of biopsychosocial model, role of bioengineering technology, and even the people's now pain experts, we can think of genetic therapy as well. We all as a medical professional should remember understanding, compassionate, careful pain assessment, make the immediate comfort for the everyone of patient with therapeutic value, making it trust and improve the tolerance. For the pain education as well, the role of drug availability, safety drug availability in the individual country is important for the pain management program. For the institutional policy, including country policies, are also important. Before ending my section, there are some burning questions are still arising in the current practice. Some of the questions are not clearly answered yet. How to assess an individual pain condition in ONE with diverse etiology and some accompanied comorbid risks? Is very comprehensive. Could we consider the treatment decision subjectively or objectively or both? Because some practitioners consider on this favor on subjective, some are favor on the objective. How to educate the patient with ONE pain and biopsychosocial counseling for the individual case programming. As a surgeon, does the surgery or intervention abolish the total pain and disability? Either the surgery can replace the multidisciplinary care or not. This is no. What patient-centered outcome measurement closely meet the realistic expectation of patient? That is the common problem. How patient personality, social cultural status, and health system delivery influence on our treatment strategies? So these are the some burning questions. Whenever I attended the international community, these questions are the everybody concerned. So as a clinical medical practice, passion, mission, vocation, and professions all work together. As a patron of our Myanmar Pain Society, I always encourage and give this information to every members. If you can feel the pain, you are alive. If you can feel the pain of other people, you are human. If you can treat the patient with pain, you are good doctors. If you are keeping in ethics and compassionate, you are the best practitioners. Thank you very much for your kind attention. And I'm
Very good discussion. We had already have some questions, but we will leave it for the last session after the second speaker. I noticed there is a chronic pain management, and it is different from acute pain. So it is also different strategy. And there are the swinging of the treatment options. Previously, we are treating with the COX-1 blockers like the indomethacin and tacrolimus, and then we switch to the purely COX-2 inhibitor like celecoxib and rofecoxib, and we then faced with some problems with COX-2 inhibition like myocardial infarction, and then we switch back to the COX-1. So in the middle, we have the preferential COX-2 inhibitor, blocking the COX-1 a little bit and blocking the COX-2 as well. So it's balancing. So Professor Rohini Handa is talking about this, elaborating the balancing action. And I would like to introduce very short. He has worked as the Dean of the Indian College of Physicians, and he has been the past president of the Indian Rheumatology Association. And he has worked as the co-chair and past president of the Scientific Committee of Asia Pacific League of the Association of Rheumatology. And now he is working as a senior consultant rheumatologist in Apollo Hospital in New Delhi, India. So you can see a lot of experience as a dean and president of the rheumatology, and we can hear the very useful words and discussion from Dr. Rohini. So please, Dr. Rohini, the chair is yours.
Thank you very much, Professor Chit. It's an honor and a pleasure to be in a session chaired by you. The talk by Professor Myint Thaung was very, very elegant and very, very contemporary. I bring you greetings from New Delhi, and my brief today is to talk about the management of chronic pain, the balancing act, and I'm going to focus on rheumatoid arthritis. We just had an absolutely fascinating talk on osteoarthritis, acute and chronic pain, and some of the contemporary issues. So I'm going to focus on basically rheumatic diseases with particular reference to rheumatoid arthritis. I hope my slides are visible.
Yeah, we are seeing you.
Yes. Now, if you look at the big four of rheumatology, four musculoskeletal conditions that are encountered in the community. We have low back pain, tops the list, followed by osteoarthritis, so very well covered by Professor Thaung. Then we have soft tissue rheumatism. And last but not the least, we have the inflammatory rheumatic diseases like rheumatoid arthritis, ankylosing spondylitis, the connective tissue diseases. In terms of commonality, it's back pain, then followed by osteoarthritis. And at the bottom of the list are the inflammatory rheumatic diseases. But if you look at hospital-based practice, it's the other way around. What you encounter are inflammatory rheumatic diseases. Now, these are widely divergent clinical conditions. A very variable pathophysiology underlies these conditions, but the recurring theme is pain. What brings the patient to the doctor is pain, and which is what we are going to discuss today. No matter whether it is osteoarthritis, and knee osteoarthritis in my country is the commonest site for osteoarthritis, or it is hip OA, or be it nodular osteoarthritis of the hands, or rheumatoid arthritis, one theme which cuts across these different conditions, and this is an example of ankylosing spondylitis, and this is gout for you. The underlying theme is pain, and this is what we are going to talk about. Pain has been dubbed as the universal manifestation of rheumatic diseases. This is now called the fifth vital sign, and this is something that I would like to share with you all. This was articulated by Prof more than 25 years ago. Behind the dazzle of the search for cause, the fundamental concern of rheumatologists and their patients is pain. The patient is not bothered about your cytokines, is not bothered about the interleukin, is not bothered about the monocytes and the macrophages. What he or she wants is relief from pain. And this has been so very well put by Prof. Unfortunately, rheumatic diseases are plagued by therapeutic nihilism. A lot of people believe that modern medicine is going to involve corticosteroids. They are apprehensive about the side effects, and they are willing to try anything and everything in order to get rid of pain. And I shall share with you some examples that all of you as clinicians would have encountered in your clinical practice. This was a young girl who presented to me more than 20 years ago, had juvenile arthritis, was told the only way to get rid of her pain is to burn out the disease, and you can see the joints were branded with hot iron. The arthritis stayed where it was. She was certainly scarred for life, both physically and emotionally. Yet another example of lupus. This girl was told that the only way is to let out the blood, and you can see the cut marks. This is digital gangrene due to antiphospholipid syndrome in this patient. And again, she was subjected to virtually more pain than the disease itself. This is yet another example, magnetotherapy, very popular in my country at least. And this is something not from the remote rural areas or the hinterland of India. This is the capital of India, New Delhi, bloodletting as a treatment for rheumatoid arthritis. And this is cupping, again widely employed. Suction is employed, and you can see these bruise marks. And this was a patient of Wegener's granulomatosis with arthritis, and she was told that the only way that she could get relief from the disconcerting pain was cupping. And I'm sure that in Myanmar too, there would be many, many such examples. So what we have is therapeutic nihilism, the patient's willing to try anything and everything, and we compete with alternative systems of medicine and the so-called self-proclaimed practitioners who claim to give relief from pain. Now, if you look at pain in musculoskeletal diseases, we have several modalities, and Professor Thaung did refer to multimodality treatment. We have analgesics, we have anti-inflammatory drugs, physical modalities like hot and cold, ultrasonics, and then of course you treat the underlying condition. In analgesics, paracetamol tops the list amongst the drugs that are widely used, especially in my country. But there has been a paradigm shift in the way that we talk about paracetamol now. In the past, this was particularly in chronic pain conditions like osteoarthritis or degenerative spinal disease. It was deemed to be effective, perceived to be safe, but this is no longer so. We have data to believe that it is not all that safe. It is not bereft of side effects, and it's not as effective as the anti-inflammatory drugs. There is a relative lack of efficacy. There is a growing recognition that this may not be totally GI safe. There could be small increments in systolic blood pressure, and it could be associated with liver and renal toxicity. So most of the current guidelines, particularly with regards to osteoarthritis, paracetamol or acetaminophen is now taking a back seat. The other analgesic that is widely used is tramadol. But when we talk about the musculoskeletal diseases, what are widely employed are the anti-inflammatory drugs. And as a drug class, they are the most widely prescribed drugs in the world. At any one point of time, 5% of the world's population is using NSAIDs, and this is a dated slide. If you look at current figures, the numbers are something like 450 million with a 7.8 billion population. And I would like to point out that not all of these are prescription drugs. The NSAID use involves over-the-counter usage also, and the anti-inflammatory drugs account for nearly 1/4 of the adverse drug reactions. Now, the saga of anti-inflammatory drugs, the NSAIDs, started with this tree. This is the willow tree, and from the bark of the willow tree was synthesized salicylic acid. This is Felix Hoffman, was a chemist working with Bayer company. His father had rheumatism, tolerated salicylates poorly. So he was the first individual to synthesize acetyl salicylic acid way back in 1899. And this was a revolution at that point of time. Over the next few decades, it became apparent that the pain relief with aspirin was significant, but with the dosages that were employed, of equal concern were the GI complications, and these ranged from GI intolerability based upon withdrawal for GI symptoms, endoscopic ulcers, perforation or hemorrhage, and rarely even death. Now, the side effects of the non-steroidal anti-inflammatory drugs were not confined to the GI tract. Renal side effects well known, aminotransferase elevation well known, and in fact, all rheumatologists in the audience would vouchsafe for this, that if you have a patient who's on methotrexate and anti-inflammatory drugs, the methotrexate might get blamed when the actual culprit is the continuous use of anti-inflammatory drugs. Then hematologic side effects, cytopenias, pulmonary problems, aggravation, worsening of asthma, CNS side effects like aseptic meningitis, cutaneous drug reactions, and I alluded to this fact that NSAIDs account for 1/4 of all the adverse drug reactions. Now, in 1971, Sir John Wayne propounded the Cox hypothesis, and for his seminal work went on to win the Nobel Prize in 1982. And this placed on a firm scientific footing the Cox pathways. This is the well-known arachidonic acid pathway. You have the lipooxygenases, the cyclooxygenases, and it soon became apparent that COX-1 is responsible for the homeostatic, housekeeping, physiological functions, and COX-2 is responsible for the pathophysiologic part of it. And this soon led to a spate of selective COX-2 inhibitors, starting with celecoxib and a lot of others. And we shall now look at this in some more detail. The year of grace, 1999, was a landmark year in ways more than one. In 1999, aspirin celebrated its 100th birthday. It was the centenary year for aspirin. And this year also saw the introduction of this molecule. This was rofecoxib. And this is the epitaph for rofecoxib. Born 21st May 1999, died a premature death 2004. And what was touted as a gastroenterologist friend turned out to be a cardiologist nightmare. And this controversy, endless debate, ceaseless controversy about the cardiac side effects of selective COX-2 inhibitors? Are they molecule specific, class specific? This triggered a lot of debate, occupied lots of space in the print journals at that point of time, so very well known to all the illustrious attendees today, which is what brings us to the balancing act. And you need to balance safety and efficacy. And this is where the COX-2 preferential inhibitors come in. And I'm going to now talk about etodolac in this perspective. This blocks the COX-2 mediated inducible actions, does not fully affect the physiological COX-1. And this is an important slide. On the right-hand side, what you see are those which are less than 5-fold COX-2 selective agents. And these include the conventional drugs like aspirin, naproxen sodium, indomethacin, ibuprofen. And then on the top of the slide are highly potent COX-2 inhibitors, more than 50-fold selective, in which we have etoricoxib, rofecoxib, valdecoxib. And rofecoxib and valdecoxib were withdrawn. And in the middle, between the two outliers, we have agents which enjoy a 5 to 50-fold COX-2 selectivity. And this is where you have etodolac grouped with diclofenac, celecoxib. And this is the balancing act between highly COX-2 selective and non-selective. This is the preferential COX-2 inhibition, and this is where etodolac figures. Now, how do we view etodolac in the context of rheumatoid arthritis? Rheumatoid arthritis is the bread and butter for a rheumatologist. This phenotype is well recognizable. You can see the rheumatoid nodules, a bilateral symmetrical inflammatory polyarthritis affecting the hand joints. And if you look at the treatment modalities for rheumatoid arthritis, up until the 50s, abrogation of inflammation and pain was the goal of treatment. Anti-inflammatory drugs were employed, mainly as the sole agents. Then burst on the scene corticosteroids, went on to get the Nobel Prize in 1950. The landscape was dominated by steroids till disenchantment began with the heroic dosages used, the side effects emerged. The late 80s, 90s belonged to the disease-modifying drugs, with methotrexate being the anchor drug. And we now have leflunomide, hydroxychloroquine, sulfasalazine. And the last 2 decades have been dominated by the targeted treatments. We have the biologicals and more recently, the JAK inhibitors. Now, if you look at the quality of life in rheumatoid arthritis patients, and this is important, they are not worried about tender joint counts, swollen joint counts, acute phase reactants. More than 70% of the patients would like to see one thing, which is improvement in pain. And this is what we need to be sensitive about. And pain has a lot of psychosocial aspects like psychological distress, feeling of helplessness, catastrophizing, lower esteem, higher unemployment, lower self-efficacy. And this is what impacts the patient most. If you have a patient who has a clinico-serologic discordance, the patient is not worried about high ESRs, high CRPs. What he wants is pain relief. How do you achieve pain relief? And this is the spectrum of treatment available in rheumatoid arthritis. The mainstay of treatments are the disease-modifying drugs, which treat the cause. The consequence is pain is treated by anti-inflammatory drugs, some analgesics, topical capsaicin, and you have some other modalities like the weak opioids, muscle relaxants, antidepressants. Focusing on the non-steroidal anti-inflammatory drugs, they are invaluable in providing symptom relief, but of note, they do not alter the natural history of disease. So by no means do they replace disease-modifying drugs. They are irreplaceable adjuncts in the treatment of rheumatoid arthritis. When should a clinician use anti-inflammatory drugs in rheumatoid arthritis? When initiating treatment with disease-modifying drugs. So if you have a treatment-naive rheumatoid arthritis patient or a patient who presents to you for the first time with active disease, you use a combination of all three agents, the anti-inflammatory drugs, the glucocorticoids, and the disease-modifying drugs. For instant pain relief, the anti-inflammatory drugs for the first few weeks or days, corticosteroids as a bridge therapy, they bridge the gap between institution of disease-modifying drugs and onset of action. And all of us know that the onset of action of disease-modifying drugs would take 8 to 12 weeks, and for hydroxychloroquine and sulfasalazine, even longer. So you institute all together, the person stays on disease-modifying drugs, the corticosteroids get withdrawn, and the anti-inflammatory drugs bring the relief to the patient. And this is why they are invaluable before the effect of your methotrexate and your hydroxychloroquine kicks in. Apart from the time of initiating treatment, breakthrough pain. No amount of disease-modifying drugs would eliminate pain altogether. So you have these patients who return to you with stiffness, occasional flares, and this is when you need to give anti-inflammatory drugs. And then, of course, rheumatoid doesn't exempt them from mechanical pain, like the patient may have osteoarthritis knees, may have a frozen shoulder, and you need anti-inflammatory drugs in this setting. And this is the essence is also reflected in the NICE guidelines from the UK that you consider NSAIDs and selective COX-2 inhibitors when you need control of pain or stiffness, and you need to individualize your treatment. What about the molecule in question? Etodolac achieves good concentration in the synovial fluid. These are the serum levels. These are the synovial fluid levels. One of the fringe benefits is the uricosuric effect that it has, and also has some antioxidant properties. And if you look at the data of etodolac in rheumatoid arthritis, this is comparison of etodolac versus naproxen, and this is versus diclofenac. And as you can see, the pain relief is fairly good with etodolac. What about safety and tolerability? These are figures of hepatic function, renal function, and overall, this is in keeping with what you have with the other anti-inflammatory drugs. No drug is absolutely safe. You need to monitor your patients diligently and carefully. Friends and colleagues, I would like to end by mentioning that etodolac is a valuable addition to the NSAID armamentarium that we have. It's yet another tool in our fight against rheumatoid arthritis. And I would like to end with this saying by John Dryden, "For all the happiness mankind can gain is not in pleasure, but in rest from pain." Thank you very much. And I hope I have got my Burmese correctly. Thank you very much. And I would like to be educated. I use the Google Translator, and I hope I have not committed any goof up with this. I do request your feedback. And if this has stimulated your interest in rheumatology, this is a book that I authored recently. Nothing theoretical about it, pure clinical stuff. Thank you very much. And I shall be happy to take up questions.
Thank you, Professor Handa, for very elaborating talk. And yes, we have to take home that the pain is most important problem for the clinical practice or rheumatological complaints, including low back pain, RA, soft tissue rheumatism, and OA. They all have the same one center problem, is pain. But as Professor Myint had mentioned, pain relief is not only depends on drugs, but also on multidisciplinary approach. Even the surgery is not the final answer for the pain relief. So we have to manage according to the individual pathophysiology and its preference. And the most important one thing, both of the speaker has not mentioned, is cost. Because some drugs, very good, like the biologics, cannot be reachable by the most of the Myanmar patients. So the main principle of management is to reduce the pathophysiology by DMARDs and biologics. Even the DMARDs, they cannot reach the target level only in 50%, mostly. And they cannot go next step to the biologic. So they still having the suffering pain. So breakthrough pain, although it means to be given when we fail to manage by treating the disease process, because we usually fail to treat the underlying cause, pathology, by biologics. We use more and more of the analgesics in Myanmar compared to the other countries. So having the safe drugs is a good news. Actually, it was introduced in India since 1970. So it has been 30 years now, 40 years now, like the aspirin. But the good thing is, because of having the long history, it ensures the safety as well. So it is the most safe drug, one of the most safe drugs, and good history. So although it coming to Myanmar lately now, it is a good timing, because we are now looking back for the balanced drug. So we can start with the, before the question and answer, I would like to invite Zydus for quick presentation about the P212, because it is the new molecule from Myanmar. Zydus, please.
Thank you, Professor Chitso. I would like to bid good afternoon to all the doctors. And thank you, Professor Chitso, for giving us this opportunity to present the product. So as have been shared by Professor Rohini Handa and of course, Professor Myint, we would like to say that when managing chronic pain, conventional NSAIDs, or depending on their COX and COX-1 and COX-2 inhibition potency, can trip off the balance. So make a preferred choice. Presenting first time in Myanmar, the preferential COX-2 inhibitor for the right balancing act. Our etogesic ER, that is etodolac extended release tablets, 400 and 600 milligram, the preferred choice for long-term pain relief. We have used the diagram from Fitzgerald hypothesis to explain that how etogesic would probably be better able to manage the balance between the TXA2 and PGI2. And as you can see here, that etodolac being preferential would be inhibiting COX-2 while having a balance in terms of COX-2, thereby keeping a balance between the prothrombotic and antithrombotic state. So benefits of the preferential COX-2 inhibition would be essentially better balance of TXA2 and PGI2, resulting in better cardiac safety than highly COX-2 selective NSAIDs and lesser GI toxicity than non-COX-2 selective NSAIDs. Thus, we can say that efficacy of preferential COX-2 inhibitors is equal to the classic NSAIDs minus antiplatelet effect. Both these graphs have already been shared by Professor Myint in terms of efficacy of etogesic or etodolac. So etogesic ER provides excellent efficacy in moderate to severe pain with long duration of action, our etogesic being extended release. So here the first setting, which is in 4 weeks, it had the efficacy has been comparable to diclofenac, while in the other setting in the knee OA patients where etodolac and diclofenac were compared for about 6 to 12 weeks, it was found that more number of patients were able to experience pain relief. And the third example that we have here is among the RA patients, the rheumatoid arthritis patients, wherein the etodolac and diclofenac were compared for about 12 weeks. And upon the final assessment between the two set of parameters, the primary parameters and the secondary parameters, etodolac 400 milligram a day could result in improvement across all the 4 primary parameters, such as the number of painful joints, number of swollen joints, or patient's global evaluation and physician global evaluation, and among improvement among 6 of the 7 secondary endpoints, while on the other hand, diclofenac had improvement in the 3 of the primary factors and 3 of the secondary factors. So we can see here there has been a significantly better improvement in RA patients with etodolac 400 milligram per day. And of course, the safety data has also been shared by Professor Myint. Of course, here I would like to highlight the renal safety, which is not very often talked in terms of the NSAIDs. So we can see here that etodolac has almost similar effect as what placebo has in terms of the blood urea nitrogen and creatinine. And this study was a long-term study for about 4 to 52 weeks, and a large number of patients were tried on, while the GI safety has been significantly better as compared to the comparator drug here. So here, one of the very interesting aspects that Professor Rohini Handa also shared about the complementary mechanisms that etodolac has in terms of inhibiting the migration of macrophages towards the site of inflammation, resulting in reduction in inflammation and higher concentration in synovial fluid, which would lead to enhanced relief in joint pain, and uricosuric effect, which brings the usefulness of etogesic ER in gouty arthritis pain, and normalization of like preserving the normal collagen phenotype, resulting in reduction in cartilage and bone damage, and inhibits the bradykinin formation, thus resulting in reduction in inflammatory pain markers, and also acts as a antioxidant by inhibiting the oxygen radicals and reducing the oxidative stress. So finally, in summary, I would like to say that in chronic pain and inflammation of osteoarthritis and rheumatoid arthritis, please consider prescribing our etogesic ER 400 or 600, which is the preferred choice for long-term pain relief. Etogesic provides preferential COX inhibition, thus preserves the balance between antithrombotic and prothrombotic states. Etogesic ER brings favorable effect with better response towards pain, inflammation, and also improves the quality of life. Also, etogesic ER has significantly better GI, cardiovascular, and renal safety as compared to diclofenac and other conventional NSAIDs, and complementary mechanisms provides pleiotropic benefits for enhanced pain relief. And etogesic ER comes with matrix release technology for longer duration of action with just once a dose convenience. So dosage of etogesic is such that in chronic OA and RA pain, for maintenance pain and inflammation, consider prescribing 400 milligram OD, and in acute flares of OA and RA pain and inflammation, consider prescribing 600 milligram OD. So with that, I would like to thank all of you for your time and attention.
Thank you for the short presentation. And so it's the time for Q&A. We had nearly 200 participants here, and we had very interesting questions. And the one I would like to start is what is the difference of chronic pain and acute pain management. So it is the main theme of this symposium. So with the privilege of the chairperson, I would like to elaborate this a little because the one thing is time frame. The cutoff time is 12 weeks or 3 months. If the pain passes more than 3 months, it is called chronic pain. With up to 1.5 months, it is called acute pain. And between 1.5 to 3, it is subacute pain. So for acute pain, the most important thing, we are looking at 2 points, safety and efficacy. So for the acute pain, most important thing is efficacy. To release the pain is most important. Although it may be a little bit more toxic, we will use. So we use the most preferential to COX-1, like the ketorolac. The ketorolac, we have the ketorol from Dr. Reddy for injection form. And then if it is not relief, we go very quickly to the ratio level of pain up to the betadines or morphines very quickly. We don't care for the dependency. So for the acute pain, the most important thing is efficacy, and we consider the safety in the back. But now, even the WHO pain letter is, we have a lot of attacks and criticisms because in America, we believe the NSAID is the most causing effect for the adverse reactions, but actually the adverse reaction is a prominent one or obvious one. But the covered one is a dependency problem and social problems. So the opiates are causing the most problem in US now. For the chronic pain, if they use opiates, they cause dependency and they have the increased crimes and increase the divorce and social problems like that. So they want to change back to the opiate-free pain relief now. Previously, the world is attacking Myanmar for less use of opiates. They are not humane. They are not good doctors like Professor Myint said. They don't relieve the pain effectively. They don't use opiates in hospitals or in clinics. Now, they are looking back to Myanmar now. Oh, yes, they are true. Using the opiates is causing the problems. So the world is now changing back to the opiate-free treatment of pain, management of pain without opiates. So in this case, the balanced pain relief is very important, especially in chronic pain, like more than 3 months. So the 4 main culprits in practice causing pain, RA, they cause more than 3 months. Rheumatoid arthritis, they cause pain more than 3 months. And low back pain, acute low back pain is there, and mostly they can become to chronic low back pain. So soft tissue rheumatism usually within 3 months, so it's okay. So more than 60% of the pain are chronic pain. So chronic pain management is very important, and the use of drugs is very important. So that is the first question. So next question is, I think, also target to Professor Myint because I think the questioner is orthopedic. His question is, he has a fracture of the knee with a car accident for having the pain for a long time. So what will be the best drugs for this? Professor Myint, please. The questioner is from Myint.
Yeah, thank you. Thank you very much. So as you have a accidents with accompanied fractures at the periarticular area, the complexity of the pain anatomic origin need to be identified very carefully with the comprehensive assessments in terms of biological assessment, in terms of mechanical assessment, and in terms of possibility of the biopsychosocial assessment as well. And you need to treat every possible risk factors. You need to protect it, and you need to give. No one drug in that stage will not give the patient satisfaction. If it is mechanical derangement, you have to correct it mechanically by means of surgery. That is the reason why whenever I saw this type of patient, even if you are willing to take the X-ray, every X-ray should be on the loading stress X-ray. Otherwise, you can miss the mechanical underlying cause. And appropriate splintage and functional brace, as well as your safety painkiller will be helpful. Plus, you need to try to explain and properly counseling the patients in both ways, either medically, socially, as well as the biopsychosocially as well. You need to counseling the patient. Otherwise, if you depend upon the only one drugs to kill the patient with this type of complex type of the pain, you will get a failure. I think you can understand my answer.
Thank you, Professor Myint. I would like to refer to Professor Handa about the question because it is also the question we would like to know. It is about the PPI coverage together with the painkillers. So, although starting from the aspirin, the main problem is the GI problem as a side effect. So, what is the policy for giving PPI to every patient or only with the high-risk patients? We have the also the risk factor stratification for GI and risk factor stratification for cardiovascular, and to choose less toxic drugs or to choose preferential drugs together with PPI. So, how is your practice now in India?
Thanks,
PPI.
Professor. Actually, coming to your question on the cardiac, naproxen is considered to be perhaps one of the most cardiac-friendly anti-inflammatory drugs. If you have comorbidities, like you have an elderly person, is a diabetic, is on several drugs, it is usual to gastroprophylax them with a proton pump inhibitor. There are some preparations which combine NSAIDs with misoprostol. Misoprostol is not widely available. So generally we use rabeprazole, omeprazole, pantoprazole with the non-selective inhibitors. With selective inhibitors, should there be a problem, you can also use a PPI. In patients with ankylosing spondylitis who are relatively young, they tolerate NSAIDs well. You do not need to offer universal prophylaxis to all patients who go on NSAIDs. You need to be selective. Young patients, short-term use, no comorbidities, you need to gastroprophylax them. But should you have a patient where there is likely to be chances of a GI bleed, adverse outcome, multi problems like in the elderly, you can use a proton pump inhibitor. At least in India, that's more widely used than misoprostol, although there are some which combine NSAIDs with misoprostol.
Thank you. So that is the point I also want to highlight, because in general practice, once they prescribe the NSAIDs, is automatically combined with PPI. So PPI is not the drug without side effect. It can also lead to the renal failure as well. So please avoid unnecessary use of PPI. You have to specify if the patient has a chance to have GI hemorrhage, and this GI hemorrhage can lead to multi-organ failure, like the patient already having heart failure. If there's some stress, it will lead to the mortality. Or if the patient has elderly, they cannot stand for any stress more, then you have to put together with PPI. For the normal adult patients without history of GI bleeding or perforations, we don't need to give the PPI. In Myanmar, main practice is the patient start with It means I had tummy problem. Every patient starting with I had a tummy problem. So every doctor they start with the PBI together with NSAIDs. So it is a wrong practice. So the next question is how to weigh loss of exercise on how to do weight loss with exercise or diet. With pain, they even lose motivation to exercise. So Professor Myint has stressed for multimodality treatment for to the pain management. And so OA main treatment is to weight loss, but with the presence of pain, they don't want to do exercise. So how will you motivate? Professor Myint, can you answer this?
I should answer that getting weight loss advice and proper weight loss regime is we need a multidisciplinary approach. Usually, whenever my patient asks to get the weight loss, I usually refer to our nutritionists and advisors so that treating the weight loss is also the multifaceted treatment. Exercise, especially in the patient with the weight-bearing joint pain, I do not recommend the exercise in the loading position. I usually recommend those type of patients with loading pain should do the unloading exercise, which can also reduce the weight partly. Plus either nutritional therapy and some of the potent drugs, which can safely reduce the weight pain, usually recommended by the physician as well. So this is the multidimensional treatment. So whenever patient cannot tolerate the exercise by means of the loading, please try to stop it, and you can advise some of the unloading exercise as well as nutritional therapy, as well as medication. Whatever you do, you can do it. Another problem is in the chronic arthritis, I would like to stress here is usually arthralgia is accompanied with the myopia as well. Some muscle and tendinous pain, stiffness, as well as even a muscular atrophy, which can be directly impact on the severity of the chronic pain as well. So you need the muscle strengthening exercise without disturbing the loading stress as well. So you need to keep the muscle and tendinous structure strengthful by doing the appropriate exercise, which should not stop the patient compliance for the exercise as well.
Thank you. So another question is also complex one, but also an obvious one. Maybe Dr. Rohini, Professor Handa will tackle that. The question is COX-2 affect to CVD risk preventable by adding aspirin?
Yes, you can. So if you have issues of cardiac disease, people do advise that long-term selective COX-2 inhibitor should not be used. Use a conventional non-selective anti-inflammatory drug or something like a preferential etodolac. Gastroprophylax those patients and give your aspirin. But should you have reason, you can combine it with aspirin. If you have bad heart disease, better to stay away from selective COX-2 inhibitors.
Thank you. So actually, the COX-2 inhibitor usage is to avoid the GI side effect. And if you are giving the aspirin, so you are putting the GI side effect again. So it is not very rational. Usually better to use a non-selective COX-2, non-selective drug like the etodolac in cardiac patients rather than putting COX-2 plus aspirin. So good. And another question is maybe the pharmacy may like this question. The question is diclofenac versus etodolac versus naproxen versus ibuprofen. Which one is more preferable? So Mr. Handa, please.
Well, I think the answer is simple. You have a place for all. If you have pregnant women, ibuprofen has a long-term safety record. It's short acting, but you need to dose it more times in a day. So you have a place for all these. There are no head-to-head comparative trials. This is yet another weapon. It's you need to individualize, go by what suits the patient most. Sometimes in anti-inflammatory drugs, cafeteria approach. One person may swear that naproxen works much better for him than does indomethacin. So, I mean, basically once a day dosing, convenience, cost, you need to blend all this. And with pregnant and breastfeeding women, ibuprofen is a time-honored safe drug, has been used for decades.
Right. Very good answer. Yes, but there are some head-to-head studies, CTs with etodolac and aclofenac, and giving the better efficacy with etodolac with lesser side effects. Also, there is some head-to-head RCT for rheumatoid arthritis, including more than 1,000 patients for ibuprofen and etodolac, resulting in better efficacy with lesser side effect for etodolac. So it is your individual choice, as mentioned by Professor Hendy, looking for the price as well, and looking for the convenience of once a day dose or twice a day dose or twice a day dose as well. And maybe we can go for the another question. It is for etogesic, can we prescribe BD if one OD is not enough?
Yes.
So,
Yes.
right. Yes. So what is the maximum tolerable dose? Because it is a 400 and 600. Usually, previous studies, they mentioned the PD dose because it is not long acting. It is a 400 milligram PD. So your drug is coming maximum of 600. So if it's not enough, can you prescribe PD? So Professor said it is okay. Does etodolac cause gastric irritation? So I think this is, as we mentioned, every NSAID have the gastric irritation, but it only depends on frequency. Said to be lesser frequent gastric irritation with etodolac compared to the COX-1 specific inhibitors. Etoricauxib in elderly patient, it causes palpitation. How about etodolac? Can it cause palpitation? The question
Can I answer
is,
this?
yes, please.
I think there's no drug which is absolutely safe and no drug which is absolutely harmful. I mean, it is not that if we are speaking at a etodolac function, we have to say it has no side effects. I mean, as Professor Thaung said, we need to monitor every person. I mean, if you have impending renal failure and you have renal insufficiency, you would be very circumspect about using anti-inflammatory drugs. Etodolac is included in that. I mean, there's nothing like absolutely safe, absolutely harmful. It's a balancing act. And all of us use clinical judgment. So if you have palpitation, any of the drugs could give rise to palpitation. There is nothing sacrosanct that this will not, others will. And no two people respond to the drug in the same way. I mean, that's why you need a man to prescribe drugs, not a machine to prescribe drugs.
Yes. And over-the-counter drugs are not free for use for long term. It is over-the-counter for only for 2 weeks. If you want to take more than 2 weeks, you need the restriction as well. But I think in India, etodolac is not over-the-counter drug. For the NSAIDs, they are different. Some are over-the-counter and some needs the prescription. How about Dodolac in India? Is it over the counter or prescription only
Actually,
drugs?
the law in India is very lax. All NSAIDs are over the counter. What happens is that
Thank
we
you.
have a lot of regulations in place, but we are a huge country and 1.2 billion people, and to monitor who buys what is almost impossible. You could get guns, you could get drugs, you could get, and NSAIDs are the least bit of government's problem. So actually, to be honest, uh, the enforcement of law is not very strict.
Right. Another question is a little bit similar from Dr. Suitin. He asks about cardiac safety of etogesic compared with other COX-2 inhibitors. So I think we already have mentioned not no drug is safe, but comparison to COX-2 specific inhibitor, preferential inhibitor has theoretically less side effect for cardiac BP, but even for celecoxib and naproxen, now there are become more study. Although we had traditionally believed naproxen is the safest one for cardiac, now they said there are the same prevalence of myocardial infarction in cohorts of long-term use of celecoxib and naproxen or ibuprofen. So some study even show COX-2 inhibitor has lesser prevalence of myocardial infarct or mortality. So the evidence are coming out again and again, and the pendulum are shifting again and again. So we have to watch the evidence, and although they are true, and although we are strong RCT, they are true for today, and we cannot take a grant for tomorrow. So we have to watch the patients, our patients, after prescribing a drug for side effects, we have to watch and we have to warn the patient for every patient. You cannot give safely any drugs. We have to watch every drugs. So other comments are for the distribution of the records. I think the company will take care of the distributing the records of here. So do you see any specific questions for, because some questions are not related to the symposium. They're just asking for the treatment problems, so like the glucosamines, and I think we don't need to answer here. Professor Midang, do you want to add something?
Yeah. One thing I saw, the one question is, what is the role of acupuncture in chronic pain management? And did you use neuro drugs in the chronic pain? It is one of the interesting question here. Just I would like to respond. In concern with this question is the role of acupuncture in chronic pain management is there, provided that they should be the trained acupuncturist. That what I mean is medical acupuncturist, not the traditional one. And they must know the etiology, they must exclude the pathogenesis, and they must have the monitor for the response of the patient with acupunctures. Whenever the pain is still persists or even worse after the 3 months of treatment, there is some neural elements and biopsychosocial elements of risk factors are coming in. Personally, I found some of the cases, even with radiological evidence of the OA in their knee, but when you carefully examine the knee, the symptoms correlated to the findings are not very much correlated and concerned. Sometimes the pain is referred up to the back, sometimes pain is referred up to the hip, sometimes pain is referred to the toes and foot as well. And when you carefully ask about the patients, this patient is really suffering the stress leg syndrome, not the osteoarthritis of the knee joint itself. So in that type of case, if you can carefully examine it, some sensory deficiency, sensory defects are there as well. That is the elements of the neuropathic pains are there. even with the after total knee joint replacement visit. So whenever the patient pain duration is more than 3 months with the proper treatment, you need to consider some of the drugs which can be used in the neuropathic type of the pain as well. So we need a combination of anti-inflammatory, neuropathic drugs, as well as the biopsychosocial assessment and counseling, plus exercise and some of the nutritional therapy. We need a combination of therapy for in that conditions. Another one I would like to stress for the audience here is there is a margin of safety for every drug there. In the perioperative type of management, in the acute case, what we usually use our surgical team is multi-action level of the drugs. Some of the drugs which affect on the central nervous system, some of the drugs which can affect on the spinal cord level, some of the drug is action on the peripheral level as well. We use the combination of multimodality approach to treat the pain as well. So there is no definite margin of safety for any kinds of the drugs. So that should be careful in every case. Thank you very much.
Thank you. Another question maybe Professor Handa can answer. This is a common problem here. For the pain management in patient having hepatitis C or B, because even in our patients, if the patient has RA patient with the hepatitis, we refer to the hepatologist, they withdraw all the painkillers because they are very afraid of the viral flare or liver toxicity. So definitely paracetamol on long-term use, they have the hepatitis and liver problem. How about the choice of the other NSAIDs for patients with chronic liver disease? Because some drugs, they metabolize in liver more and less on the renal, and some drugs, they release from renal more and less in the liver. So like the Lindex, we use more in the renal failure patients. So is there any preferential drugs for chronic liver disease? Professor Handa, please.
I don't think that where you have multimorbidities happening, you can have an absolutely safe drug. The trick lies in trying to control the disease. If you control the disease and reduce the reliance on anti-inflammatory drugs, that might be the way forward. Hepatitis C is now a treatable disease. Hepatitis B is manageable. So I think one can try and use intra-articular injections if required. For example, if you have a knee osteo flare-up, you can judiciously employ intra-articular steroids, physical modalities, and as Professor Thaung said, well-trained acupressure using alternative ways so that the reliance on painkillers goes down. I don't think that you can dissociate totally one from another. There are no easy answers for this kind of a scenario, real life scenario.
Thank you. So it's a time for closing. I would like to hand over the section to the Master of Ceremony.
Thank you, Professor Chit. It was a very interesting discussion. I think after the two very elegant talks, discussion really justified the theme.
Yeah.
After the very two elegant talks, I think the discussion truly justified the theme of today's event, that is the balancing act. And all our resource persons, starting with Professor Chitso, Professor Myint, Thaung, and Professor Handa, have truly given due consideration to all the questions from the audience. So it was really a very, very interesting discussion. And with that, now I'd like to hand over Dr. Neshwe Ong for the formal vote of thanks. Dr. Neshwe Ong.
Thank you. Yes, as you see, I'm အားကြီးအားလုံးပဲငါရှိရနေတယ်ပါခင်ဗျာကျွန်တော်တော့ဒေါက်တာနေရွှေပါ Jadi saya sekali lama jimu jemare chronic pain management the balancing act life webinar ကိုအောင်မြင်စွာနဲ့ပြီးဆုံးခဲ့ပြီဖြစ်ပါတယ်။ခုစွာဆွေးနွေးပြောကြားပေးပါတော့ chair ဖြစ်ဆောင်ရွက်ပေးတဲ့ဆရာကြီး Professor ဒေါက်တာချစ်ဆို speaker ဖြစ်ရှင်းလင်းဆွေးနွေးပြောကြားပေးတဲ့ဆရာကြီး Professor ဦးမြင့်တောင် Professor Rohini Handa တို့ကသူ့ပဲကျေးဇူးတင်ရှိပါတယ်ခင်ဗျာ။တို့ပြင်အချိန်ပေးပြီးနားထောင်ဆွေးနွေးပြောကြားပေးတဲ့ဆရာကြီးဆရာမများအားလုံးကိုလည်းကျေးဇူးအထူးပဲတင်ရှိပါတယ်။ Itu just ia itu dollar extended release 400 300 mg ဆိုရင်အလေးသက် battery ကနေပြီးတော့ထုတ်လို့တဲ့ first time in မြန်မာဆေးတစ်ခုလည်းဖြစ်ပါတယ်။ Itu just ia ဆိုရင်ကျွန်တော်တို့ patient benefit ကောင်းတဲ့ဒီတစ်ခုဖြစ်တာကြောင့်ဆရာကြီးဆရာမကြီးများရဲ့နာရီမှာလည်းကြီးညွှန်းသုံးဆွဲပြီးဖို့လည်းမေတ္တာရက်ကန်တောင်းဆိုရင်းညီကုန်းချိုးလိုက်ရပါတယ်အားလုံးပဲဒါကျွန်းတဲ့နေ့လေးဖြစ်ပါလိမ့်ခင်ဗျာကျေးဇူးသူပဲတင်ရှိပါခင်ဗျာအားလုံးပဲကျေးဇူးပါခင်ဗျာ
Handa, wish you all the best. Yeah.
Okay.
Thank you, professors.
Wishing for the coming New Year. Happy New Year.
Thank you very much, sir.
Thank you, sir. Thank
Bye-bye.
you so much
Bye-bye.
for being with us. Thank you so much.
Bye.
It was a wonderful
Thank you very
talk.
much.